Thank you so much, everyone, for joining us again for our latest media briefing on important healthcare issues in the news. I'm Dr. Samantha Hill, President of the Ontario Medical Association. We represent more than 43,000 doctors and medical students across the province, and we're here to help. This week, we're here to talk about what we have learned about the COVID-19 virus in the years since the World Health Organization declared a pandemic on March 11th, 2020, and the Ontario government declared a state of emergency on March 17th, 2020. What a year it's been. This week, we also saw the opening of the government portal where people can book appointments for vaccinations. With the arrival of the AstraZeneca vaccine and the involvement of family doctors this week, we are seeing for the first time vaccinations of large numbers of our friends, relatives, colleagues, and neighbors. After a very long year, hope and optimism are in the air. Yet, we continue to see the spread of COVID variants, which now make up almost half of all confirmed cases. Our colleagues at the OHA declared us in a third wave. So we're also going to need to discuss today the need to continue to follow all of those public health measures we've been talking about for the past year. And we need to keep following them because they've been proven to work. Physical distancing, hand hygiene, testing, tracing, and isolation. And then we're going to talk about what happens next after you've been vaccinated. Does that mean that you can take off your mask, hug your grandchildren, and have people over for dinner? Short answer, no, but we'll get to that in more detail later. I have 4 esteemed physician colleagues with me today who have all been on the front lines of this pandemic. I'd like to welcome Dr. Isaac Bogoch, an infectious disease consultant and general internist at the Toronto General Hospital, and a member of the government's COVID-19 Vaccine Distribution Task Force. Dr. Zain Chagla, an infectious disease physician at St. Joseph's Healthcare in Hamilton, and chair of the OMA Section on Infectious Diseases. Dr. Vinita Dubey, Toronto Public Health Associate Medical Officer of Health, and Dr. Mariam Hanna, a pediatric allergist in Burlington and vice chair of the OMA Section on Allergy and Clinical Immunology. Thank you so much, everyone, for joining us. Let's begin. How has the COVID-19 virus surprised us? What are the top 3 things that we've learned about in the past year? I'm going to turn this over initially to Dr. Chagla.
Hi, everyone. I think the biggest thing that that changed the game really when we started figuring out in March and April was the fact that people are very transmissible in the 48 hours prior to them developing symptoms, which made much of our ability to see an end to the pandemic with just contact tracing and quarantine a whole lot harder. And B, the fact that people could transmit completely without symptoms, although not happening a ton, it is a part of driving growth in our communities. But B, the fact that people's symptom complexes can be so minimal, a scratchy throat, a headache for a couple of days, feeling off and a bit unwell, where again, that typical respiratory stuff was not as apparent in some patients. And it really did drive much of the changes towards, our use of physical distancing, our use of masking, how we treat patients, how we screen patients, and realistically, again, the vaccines being such an important part of disease control, knowing that, again, people can spread when they're not necessarily feeling unwell. The second part, and again, this is more inspirational for sure, is the fact that we could develop a vaccine this fast, but not just one vaccine, to have multiple vaccines coming to the market. We recall, seeing news reports of COVID-19 on New Year's Eve in 2019. In mid-December, we were vaccinating people with the Pfizer vaccine. So to get to first reports to, large scale vaccine campaigns in a year, it has never been done in history. For a respiratory virus, there was always a little bit of a concern it wouldn't be as good, or kind of like the flu shot where you get some benefit, but not a particularly great benefit. But to see 4 and even 5 coming soon effective vaccines on the market that actually in real world data are controlling the epidemic when given in large quantities I mean, I don't think I could ever predicted that. I don't think anyone around this table could have predicted that. And, it is a real positive sign for human ingenuity and science.
I couldn't agree more. I often compare it to how people must have felt when man first landed on the moon. It just seems like such an incredible feat of science, and we've lived through it, and makes you wonder what we couldn't do with the same amount of resources and help from our colleagues and friends. Dr. Dubey, is there anything you'd like to add to that?
I think we've learned a lot about this virus, how it spreads, and actually how we can prevent it. And we've actually gone into our public health toolbox and took out a lot of low-tech tools to prevent the spread, and it's actually worked. Who knew that physical distancing would be something that would now be top of mind? Wearing masks, a year ago, we were not recommending it, and now we know that masks, just going to the grocery store wearing a mask is just as important as wearing a mask when I'm working in the emergency department. So I think we've learned a lot about how to control the spread with basic public health tools while we wait for the vaccine. And we're still learning more, because now the virus has changed and there are variants, and now they're more transmissible, but how else can we keep going? And I think there are a lot of surprises. We were able to open schools and keep schools open. We were able to open back up the hospitals to allow people to get healthcare, for example. So I think there's a lot that we've learned, and I think that we will continue. Those infection prevention and control practices that we're doing have almost stamped out influenza this year. And so we've actually, while it's been such a sacrifice for everyone, we've actually had gains in other ways that we didn't intend to receive.
Absolutely. And, after such a hard year, it's really important to keep an eye on those positive outcomes. And I do wonder how much of this is going to continue once we get past this part of the pandemic, once everyone is immunized. We know that we're only immunized for that one virus, but these measures have turned out to be effective for many respiratory viruses. And that's something that we will learn from and continue, I'm sure, in many ways as we go forward. Moving to our second question, and I'm going to start this time with Dr. Dubey. How is the virus behaving now? And from there, we'll leap into how safe are the vaccines, because I know for many people, those are very linked.
Yeah, so the virus has changed. The virus has mutated, and now we have variants. And we're in a very critical stage. Again, I mean, we've said that a lot in this pandemic, but again, it's a different stage where almost 50% of our current cases are variants of concern. And the reason why that's concerning is because we know that these new variants can spread easily, can cause more severe illness. And so it means, though, that the public health measures do work, it's just that we need to be more rigorous about them. We need to make sure that that mask is a 2-layer mask with a filter in it, and that we have good fit for it, for example. That we stay home as much as possible, that we limit our contacts, because it's that contact that will spread this virus, these variant viruses. And so we need to really increase our vigilance to be able to get ahead of this.
Great, thank you so much. And I appreciate that reminder that our masks, we now have better guidance on them. And we do know that they need to be those 2-layered masks, plus or minus filter, as feasible. And so it's an impressive amount of learning we've all done in the last year, to be honest. Dr. Hanna, we haven't heard from you yet. Do you want to tackle the safety piece?
Absolutely. So hi, everyone. I will say vaccine safety is a longitudinal process. It doesn't stop when the trials end, it continues. And the more data that we gather from immunizing others and seeing real world experience adds to the safety piece that we are learning about with this vaccine. We are all on high alert, including patients and physicians, and we are looking to make sure that the vaccine continues to be safe and efficacy is continuing to be looked at, including with the variants and the vaccines that we have. The vaccines were developed at a phenomenal pace, but they continue to amaze us as to how well they are doing in terms of efficacy with the dominant strain and with the emergence of the variants and the safety data that is being shown. I always like to tackle the pediatric piece. So not to fear, while we do have 4 approved vaccines and only 1 with the indication for 16 and up, it's coming soon. right? The trials for 12 to 15, especially with the mRNA vaccines, have now finished enrolling patients, so we can look for data to come in the fall, hopefully, or in the coming months to help us to address this key piece of developing herd immunity. Kids are part of the herd, they're an important piece, even though they've been doing their part and have been thankfully been able to resume school and in-school learning, we know that they will eventually be a component for maintaining or establishing herd immunity.
Absolutely. And while we're talking about children, let's just predict the future a little bit. Do we expect to see any issues? Obviously, we won't know until the data comes out, but what's your guess?
So we like to take guesses in medicine. My guess is for at least the first part, for the 12 to 15-year-olds, what we can expect is that the vaccine should behave in a pretty similar manner as has been behaving in the older age group. I don't think that would surprise too many of us. As we go into the younger age groups, there certainly can be a change that is seen in terms of number of doses or how you space them out, or variations of that. I'm not expecting too many surprises. We can see that from immunizations or other immunizations that children receive in addition to the ones that boosters that adults get. In general, they're pretty similar in terms of doses and spacing out.
Thank you for humoring me on that one. I know we don't like to guess in medicine, but I think as we get closer to it, it's good for people to have heard that we think it'll all work out for children as well, prior to us asking them to go get them vaccinated. What about pregnant women? Anybody want to talk about that? Dr. Chagla? Picking on you today.
Yeah, absolutely. I mean, again, there's nothing in these vaccines to suggest they're not safe in pregnancy. You know, they're new platforms, and so this is always the concern, obviously, in vulnerable populations like pregnant women, that you know, it's just an untested vaccine. These are vaccines that essentially trigger our bodies to make proteins. These are not live vaccines. And so realistically, again, there are vaccines we give in pregnancy, like the influenza vaccine, the pertussis vaccine, to actually protect women and baby. There's emerging evidence that antibodies actually do get transferred to the baby for SARS-CoV-2, which is actually important for their own protection. You know, many professional societies have said, you know, this is a risk and benefit discussion, but given the fact that you know, that there doesn't seem to be any mechanism of teratogenicity. We are starting to see data now of women that have delivered after getting this in the third trimester, not seeing any adverse outcomes on that sense. B, we know women in pregnancy do have an increased risk of complications with COVID-19, particularly a slightly increased risk of critical care and hospital stay. That, you know, a fair discussion of risks and benefits should be put. And again, right now, it really does seem like the benefits of a vaccine in this age group outweigh the risk, but still as a personal decision, one-on-one with your healthcare provider. So, you know, our assessment centers, our vaccine centers are willing and able to take pregnant women, knowing that they have a discussion around this. And again, you know, there is certainly a risk associated with being a pregnant person right now and getting COVID-19 that has to be weighed against the balance of potentially getting the vaccine and preventing it.
Absolutely. Thank you so much for that. Like with so many things about COVID, it's highlighted an increased risk that already exists and has magnified it. So various socioeconomic factors, pregnancy, all of the patients who are generally at higher risk for a variety of things seem to have found themselves at higher risk for COVID as well. And that's unfortunate because it's made it a challenging year for people. We haven't talked about the over 65 age group. And so I think I'll turn over to Dr. Bogoch for that one. Do you want to touch on the over 65 group?
This is the part where I talk while I'm on mute, as I've never done in the entire year. Oops, I do this all the time. Hi, everyone. Thank you. I'd love to chat about over 65. We know, I mean, for starters, let's just look at who gets sick and who dies from COVID-19. And it's, you know, of course, we know there are social determinants of health. We know that there's various medical conditions that put people at greater risk for infection. But if you really want to look at the biggest risk factor for severe outcomes, hospitalizations, and deaths, it's age, followed by age. Age reigns supreme. If you look at Canadian data, for example, over 90% of the deaths related to COVID-19 are in people over the age of 60. currently when we think about the vaccine, on the vaccine front, yeah, there's a lot of chatter with regards to which vaccine is better and which one has better efficacy and which one has better real world clinical data driving its use. But at the end of the day, when you look at any vaccine that's available in Canada, they all do the same thing. They all prevent you from getting COVID-19. And of course, they're not perfect. And if you're unlucky enough to get COVID-19, they all provide significant protection against hospitalization and death. And in the midst of a public health crisis, which this is, in the midst of, in the context of sitting on perhaps the cusp of a third wave, the right answer is you should get whatever vaccine comes available to you because all of them will significantly provide protection. I think the other thing to appreciate is things change with time, and what the policies in March and April might be very different, of course, than policies 6 and 9 months down the line. And I think it's fair to say that, in several months from now, when the dust settles and when, COVID-19 isn't, when many of us are protected, there probably will be a point in time where where there will be recommendations for, vaccine A to be given to this particular group of people and vaccine B to be given to that group of people. I just don't think we're there yet. And I really think that any vaccine that we have available in Canada will do exactly what we want it to do, which is prevent you from going to hospital and dying from this infection. And then later on, when the dust settles, we'll be able to have more nuanced and meaningful recommendations for the vaccines.
Absolutely. So you've touched on some really important points there, and I'm just going to double back on them. First and foremost, that all of the vaccines are great at preventing death and hospitalization and all of the worst outcomes of COVID. The second thing you touched on a little bit is that we can't really compare the efficacy numbers from one vaccine to another. And of course, that's a little bit sciencey, but can you explain in real people terms why that 66 and those 92 aren't comparable numbers?
Yeah, absolutely. So I think it's fair we have a couple of different vaccines that are available. So the mRNA vaccines, like the Pfizer and the Moderna vaccine, they were really tested in an era where there weren't that many circulating variants of concern, whereas some of the other vaccines, like the AstraZeneca, the Johnson & Johnson, the Novavax, those were tested in an era where there were way more circulating variants of concern. So when you start to see those, 95% efficacies versus the 60, 70, 80% efficacies, that playing field is much more level than those numbers suggest because of the variants of concern. Having said that, I think it's important to recognize that there probably will be a vaccine that performs better than the others. Like, I think we'd be foolish to think that they're all exactly the same. They're not. They're not. There probably will be some where we'll say, you know what, based on the immunogenicity or how this responds to someone's immune system, we might want to use this vaccine in this age group. We want to use that vaccine in that age group. We do this with flu, right? Over the age of 65, we give particular flu vaccines to people over the age of 65 and other flu vaccines to people under the age of 65. Like, there's precedent for this. We do this en masse. And that's probably going to happen with these vaccines as well. But right now, March and April and probably May of 2021, I think that's not the right approach. The right approach is all of them prevent you from getting sick. All of them prevent you from going to hospital. All of them prevent you from dying. Take whichever one becomes available, because down the line, sure, we might have some more nuanced recommendations. But right now, let's just save people's lives. Let's prevent people from dying.
I couldn't agree more. I mean, the truth of the matter is right now, there isn't a choice of vaccine. Right now, the choice is vaccine or not vaccine for still a select number of people, not even for everyone across the board. So speaking of safety and science, let's go back to Dr. Chagla. And would you be kind enough to touch a little bit on the reports of blood clots with AstraZeneca vaccine? I know that some people are quite worried about it.
Yeah, I mean, so there's a few things with the AstraZeneca vaccine to clear up. I mean, I think one is, as Dr. Bogoch had gone through, is the efficacy issue, and people do kind of compare back and forth. AstraZeneca is unique in the sense that it is a adenovirus vaccine, so it's a little different than the mRNA vaccines. These are actually vaccines that probably get better as you space them apart because our immune system really does need time to kind of let it cool itself down before it sees another one of these to boost it up. And so when they actually reanalyzed all the trials and they kind of pushed it apart, it is closer to about 70 to 80% effective in preventing symptomatic COVID-19. So again, in that same ballpark as the other vaccines. The blood clot issue is something that has come up recently. And again, there is always going to be post-marketing surveillance, as Dr. Hanna had mentioned, around many of these vaccines. This is how we monitor in real life. You can only do clinical trials up to tens of thousands of individuals. When you get to the millions and you start seeing the minor side effect, it can occasionally start showing up there. And again, you have to start determining this. There have been 17 million people that have gotten the AstraZeneca vaccine and about 37 cases of thromboses that seem to be associated with it. Is it enough to say there's not an issue there? No. I mean, I think the European Medicines Administration and the countries in Europe are saying, okay, let's hold off for now, this particular batch. Let's just see if there's an issue here more than not. But I wanted, to draw the numbers for you. 17 million is the kind of the population of Ontario. If you took 17 million people, the entire population of Ontario, you called every single emergency room tomorrow and said, how many people did you have with a clot that were sitting in your emergency room yesterday? You would get more than 37 people calling back and saying, yeah, I saw one. You'd probably get in the range of probably 50, 60, 70. And so this is where it gets very difficult to tease out. Is this a real signal, or is just this, following 17 million people for a set amount of time, certain things are going to happen to them that are part of natural life that have nothing to do with the vaccine. So the administrators are looking at this, they're looking at the causality, they're looking at how it relates, they're looking at risk factors for these people, they're seeing if it's reproducible and coming up to a decision there. I think for us as Canadians, the signal is exceptionally low if it does exist. And again, it's still safe going forward. B, the risk of having a blood clot with COVID-19, natural COVID-19, is not minimal. It is, in some series, up to 2% of symptomatic individuals have some sort of clotting issue associated with their COVID-19. We give patients who come to hospital with COVID-19 blood thinners as part of their therapy because they're at such high risk and, again, develop these complications. And so, there's something about a risk and benefit discussion there in terms of, there might be this minor issue with clotting as compared to a major issue with clotting with natural COVID-19. And I think the third thing is, the Europeans seem to think this is a batch issue. Our vaccines are from the Serum Institute of India, which is, the world's largest distributor and creator of vaccines. And again, if it is a batch issue, it's not the batch that we're receiving here. There are many other places like Australia, England, that continue with the vaccine campaign. AstraZeneca is a reasonable vaccine. It is probably the vaccine much of the world will receive because it is made with an altruistic model. And again, I think given the risks and benefits, the fact we're in a public health emergency, continuing to go forward, especially now with over 65-year-olds, is going to be so important for us to get through this in that sense.
Thanks so much. So briefly, we're not sure it's an issue. It may just be regular prevalence across the population. If it is an issue, it's likely to be a batch issue, and it's not the batch we're receiving. And thirdly, there is a natural tendency for blood clots in COVID that is much higher than the signal that's even been demonstrated with the vaccine. I think those are some great take-home points. I'm going to ask one more question about the safety piece, and then we'll move on to how we go forward. And so the next question is about the time between the first and second doses. And there's been a lot of talk about whether the decision to extend that time beyond the manufacturer's guidelines is appropriate, right, wrong. People like big words like that. I'll turn this one over to Dr. Hanna. Do you want to take that one?
There we go. Yeah. So again, what was done in the clinical trials versus real world is the discrepancy or the change that we are seeing here. The clinical trial data certainly suggests a specific time point, but that said, we are almost at the point with vaccination and real world vaccination that we have vaccinated more people than were enrolled even in the clinical trials. And that real life data is certainly of value. So I will say that the recommendations are changing. I think some of the reluctance is the manufacturer recommendation certainly uses a specific time point versus what we are able to do and offer in Ontario or in other parts of the world. other parts of the world are adjusting based off of what they are seeing with real life data in response to the vaccine. And certainly that kind of real life experience cannot be undervalued, and I think needs to have some bearings as well. It's an evolving story, and I think that's kind of what we've seen with COVID throughout the past year, and many people will reflect on our learning about COVID has changed over the past year. Our learning with the approach to vaccination, essentially at the beginning, we want to adhere as closely as possible to what was shown in the clinical trial. But in medicine, real world data will change kind of our approach to vaccination, and that's what's happening kind of on a live pace.
Perfect. That's amazing. Thank you so much. I'm going to jump ahead to this next slide. I've had my shot. Now what? Because I know Dr. Bogoch needs to leave us. He has been nice enough to grace us with his presence, but he's a little bit overextended right now. Everyone wants him. So Dr. Bogoch, I've had my shot. Now what? Can I stop wearing my mask? Can I hug my grandchildren? I don't have grandchildren, but can I have friends over for dinner? Can I go out and kiss strangers? What are the rules now?
Well, we're not talking about kissing strangers on this. We'll keep it PG-13. So short answer is we need a playbook, right? We need a national playbook on what is acceptable and what is not acceptable behavior. And we're entering this bizarre period of time where some of us will be fully vaccinated, meaning you've completed your course of vaccination. If it's a one dose Johnson & Johnson, which we don't have yet, or 2 doses of whatever other vaccine we have, and you're 2 weeks post that. So some people have completed a vaccine series. Some people will have 1 dose of a 2-dose vaccine series, and some people will have no doses of a vaccine series. And just like the US CDC came out with guidance on how people can interact with each other in this interim period of time, we certainly need the same thing in Canada. We know that 2 weeks after your first dose of a vaccine, you definitely have some protection. You do. It's probably different in different populations. For example, older populations and immunocompromised populations probably don't have that same degree of protection that younger individuals do. So it's extremely important to have standardized guidance at a national level on what is acceptable and what is not acceptable. But quite frankly, without that, you're going to get different opinions from different people. And a lot of these are going to be driven by our understanding of the data, which of course changes with time, plus individual risk thresholds, risk appreciations, risk tolerances as well. So it's not a simple answer. What can you do? Because the question is, what can you do after 2 weeks after 2 shots? What can you do 2 weeks after 1 shot? And what can you do without any vaccines in this current context? Tricky question. I think if you lined up 100 people in medicine, science, public health, medicine, infectious diseases, you'd probably get several different answers. My bias is I think the CDC guidance is fantastic. I really think that once people have had 2 doses of a vaccine, you really do have significant protection. And I really like how they said small gatherings, right? We're not packing restaurants and bars yet, but small gatherings in your home with other people who are fully vaccinated can be done safely without masks and distancing. I mean, well, that's the whole point of vaccination in the first place, like just to help move us back to normalcy. I really like the CDC's guidance as well of, if kids or grandkids, for example, aren't vaccinated yet but at low risk, grandparents who are fully vaccinated can certainly hug their grandkids and you can have close contact there. I think that's very, very reasonable. I also think it's reasonable that people who are fully vaccinated that have had an exposure, who are completely asymptomatic, they don't need to isolate. I think that's, so the CDC has some very pragmatic, reasonable discussions. But of course, we don't yet have that in Canada, and that advice can't come soon enough. What you can't have is having different municipalities or different provinces say you've got different expectations of behavior. Like there really needs to be a national standard on this.
Fair enough. So much like everything else that's come before us, it's complicated, it's evolving, and there needs to be consensus and clear communication. Thanks for that. If you can stay with us a bit longer, we have other questions. And if not, thank you so much for your time. It's been a pleasure.
I have to go. I apologize, but thank you for having me here. Take care.
All right. Well, then thank you to Dr. Bogoch, but also Drs. Chagla, Dubey, and Hanna. We are going to open up our Q&A session. I think we have 2 great questions there to start with, and I know this is a topic that we could all talk about for hours on end. So we're going to ask you to put your questions into the Q&A chat. As always, if we can't get to your questions due to time, the media team will follow up with you and make sure that you get an answer in print. You can also email us at media@oma.org with additional requests for interviews. We will also have a recording of this session available later today. So moving to the first question for Dr. Chagla from Barry Today, Marge Broodman. What are the concerns with the variants, particularly those from Brazil and South Africa that have started to emerge in Ontario? How do they differ from the UK variant?
So it's a great question. So these variants are essentially prior virus that have acquired mutations that change two things. One is particularly with the 501 mutation, which is common to the P1 variant first described in Brazil, the South African variant B1351, and the variant first described in the United Kingdom, B117. This 501 mutation may increase the ability to infect people. And this is where we see this type of explosive growth. We saw what happened in the United Kingdom over the December-January period, where they saw a significant amount of growth. And we've seen cases like in Newfoundland and in Roberta Place, where there's been fairly large growth very quickly. The mechanism isn't very clear. It may be the fact the virus sticks to the respiratory tract much stickier than before, and that's where that mutation occurs, or that the viral load, so the amount of virus people shed when they're infectious, is much higher, or a combination of the two, which just makes it much easier to infect person to person to person. The variant described in South Africa, B1351, and the variant in Brazil, P1, also have another mutation which is of concern, the 484 mutation. And this mutation really is in one of the bends of the spike protein. The concern is this bend is where many of our antibodies bind. Now, it's not the entirety of it, but it is one place where antibodies bind. And when we look in lab series, trying to see patients with antibodies that we synthetically make in the lab, antibodies with survivors of COVID-19, we see the amount of antibody that binds to this virus is much less than the virus that's currently circulating out there, and even much less than the virus that's described in the UK, B117. And so, there is a concern here, particularly as this starts spreading, that you not only see, more people getting COVID-19, but those who are naturally immune, potentially even, those who have some degree of vaccine immunity, it may break through and cause people to develop COVID-19. Now, good to know the vaccines are largely still appropriate for this. Johnson & Johnson has clinical data in B1351. AstraZeneca did have some clinical data suggesting in mild cases it may not work, but there is emerging data in more severe cases it may still be reasonable. Moderna and Pfizer levels are a bit lower, but still within the range that would have significant effects. And then Novavax as well seems like, again, still within a level where it's preventing disease amongst those with these mutations. But obviously there are concerns, there's surveillance, there is going to be a need probably for some degree of boosters, particularly with these mutations in mind, such that people are boosted up and their immunity can also deal with these mutations as well as anything else. So certainly a lot of change, a lot of progress, a lot of surveillance. We are testing for all of these as part of every isolate that's coming through the lab in Ontario. But yeah, the different concerns around UK, which is more transmission, versus South Africa and Brazil, which are immune escape rather than just transmission.
Thank you so much for that very thorough answer. You touched on the idea that we might need to have an annual or a booster shot like the flu shot. Let's hear from maybe Dr. Dubey. Do you want to touch on that topic? Do you think that'll be necessary? Do we have any evidence?
Well, I think we're going to have to wait and see. We're going to have to see what happens with COVID too. I mean, if we get herd immunity where we can actually really stamp out the virus, we might not have as much spread needing further vaccination. I mean, that's the ideal situation. I think keeping booster doses are something that's common with a lot of different vaccines, either to change the vaccine slightly based on a new strain that's circulating, which is what we do for influenza, or for other vaccines like our pneumococcal vaccine to prevent pneumococcal disease, we give booster doses. So I think the good news is that's something that we can look into, and certainly the science science can actually reassess that and, if needed, provide it. The other thing to note, though, is that even if the current vaccine doesn't provide the exact protection for which it was intended, there's often cross-protection. And we see that with flu vaccine every year as well, too. And so the current vaccines, even if the virus continues to change, will provide often a level of protection more than without being vaccinated.
My turn. Thank you for that. So there are two questions in the chat which are fairly similar. One is from Sharon Kirky at the National Post, and the other one is from Holly Mackenzie Sutter at Canadian Press. And they both want a comment on, are we or are we not in a third wave? If we are in a third wave, how did we get here? Is it due to the variants of concern? And do we think it's because of a slow vaccine rollout? Sorry, I censored that answer a little bit. That plodding vaccine rollout was the question. Is it a combination of both? And if we are in a third wave, do we expect to see an increase in hospitalization and deaths? With Holly's questions focusing a little bit on whether or not you agree with the comment of the third wave, what does that comment even mean, and where we take it from there. So a little bit to unwrap in there. Let's start with Dr. Hanna, and I suspect we'll want to hear from all three on this one.
I don't think it surprises us too much to hear that a third wave is either coming or we've started it. I think the logistics as to when it's officially termed the third wave, that maybe we differ in a couple of days or a week, but I think we have certainly seen a change in the numbers, a change in the percent positive for variants. And I do think that certainly does have a role to play. So are we in the third wave of COVID-19, or is this like a new pandemic of COVID-19? Is this the twindemic that I heard some people coin before? That's certainly, I think, going to become more apparent over the coming weeks here. It's multifactorial. Likely there is a role to say that the number of variants that we are detecting, now that we are testing all samples for the presence of variants, is increasing, but certainly we know that they can multiply and they can be seen in the general population and cause growth of the number of positive cases more quickly. So that certainly does have a role to play with it. Our vaccine rollout, so slow to start, but there's all kinds of optimism that it is going to pick up. The vaccine really is the answer. This is our shot to stamp this, to flatten this. Is it going to be there in time for this third wave? That's hard to tell, because it's hard to see how quickly we're going to get vaccines in arms, in patients, in people, in the population. But that certainly has a key thing to do with what we're going to see with this third wave. As for the effect on hospitalizations and deaths, Dr. Bogoch mentioned it before he left, is that the biggest impact has unfortunately been in our elderly and our marginalized communities. And I'm hoping that those are the ones that we make a huge emphasis to vaccinate first. Is it going to be quick enough? That part, I think time will tell.
Absolutely. And there's been a lot of talk about the race of variant versus vaccine, and unfortunately, there is no way to know for sure until time runs its course. You know, that was a really thorough answer, but I do want to give the other panelists a chance. Does anybody want to comment on that more?
Sure, I could just add to say this is what we know is the normal COVID as we know it is on the decline, but variants are on the increase. And so what we were seeing, I can say in specific for Toronto, we were actually plateauing. Our cases were plateauing. Now they seem to be on the upswing, and the reproductive number, which is a key number, is higher than 1. And when it's higher than 1, it means that each person who gets COVID is more likely to spread it to more than one other person. So that's certainly a sign that our cases are increasing. I think to say that we're in a third wave, you have to really show that you have increased case rates that have been sustained and are not little blips. And I think that's probably the hesitation you're seeing in terms of, do you define it as a third wave or not? It's, you know, you can get these kinds of ups and down swings, but there's no question to say that the variants are on the rise. That is for sure. And if we see more cases, you can expect to see then the hospitalizations and deaths to be associated. except where people are vaccinated, and that will certainly make a difference. And we've seen that. I mean, the long-term care homes are such a great example of a closed community where very high vaccination rates among residents, and the cases have really just plummeted. And so hopefully, as we approach, another wave, we will have this protection around some of our most vulnerable to help prevent some of those severe outcomes.
It looks like Dr. Hill is frozen. I will just put a little bit of a 2 cents in that. One, I do think is the question asked, are we vaccinating? Is it because we haven't vaccinated fast enough? At this point in the vaccine campaign, really, the race is not necessarily to bring rates down with vaccination. You really do have to get to a general population to get to that point. The race is to really get the vulnerable vaccinated such that whatever growth we see in the community really attenuates those hospitalizations and deaths, as we've been seeing in long-term care, that even what's going on outside of long-term care isn't having as much of an impact in long-term care moving forward. And the other thing I just want to mention, we do talk about growth and we talk about populations. It is very clear, and even data from Toronto is that not every population is affected equally by COVID-19. We see disparities based on income. We see disparities based on essential workplaces. And with these variants circulating, with slightly more socialization, with increased growth, we still have vulnerabilities in many of those settings still for people to get COVID-19. And so, even with or without public health measures in mind, really, really, really supporting those communities of essential workers, of those scarcely housed, of those at the fringes, basically, is going to have huge effects on us trying to control COVID transmission until those populations can get significantly vaccinated and move forward.
It looks like Dr. Hill is frozen again. So actually, I see one of the Q&As is about drive-through vaccination. So maybe I'll take that. I don't know, Leslie, if you want to jump in. But the question, I think, is drive-through vaccination safer, and why are we not doing more of it? And I think what we know now is actually how to prevent the spread of COVID in clinical settings. And so I do want people to know that when you come to a COVID vaccination clinic, there will be measures in place to ensure that you will be protected there and are not going to catch COVID there. And that includes that pre-screening to make sure that you don't have symptoms before you come. And if you have symptoms, that you can re-register and change your appointment date. And then all of the measures that will be in place, the physical distancing, the heating and ventilation, making sure that the staff are wearing PPE, that the clients are wearing their masks. And then the real bottleneck actually in clinic space is the aftercare, where everyone is to stay for a minimum of 15 minutes. And that's where you actually, getting the needle in the arm is actually very quick and painless mostly, but you need enough space to be able to have people monitored. And I think the point on drive-through clinics is they can be done quite well and quite safely, but you need to be able to have a mechanism in place to be able to watch people afterwards so that they can stay for their 15 minutes. We know that most of the severe allergic reactions, those anaphylactic reactions, the vast majority will occur within 15 minutes. And so that's another consideration when thinking about drive-through. Okay, so Dr. Hill, are you back? Oh, she's frozen again. So I don't know if anyone else wants to add anything on that one.
I think there's one other question. I think we may have skipped past it, but here, I'll read it to you, Dr. Chagla. I think you can comment about this. If a person who finishes 2 doses, can they be a carrier or not?
Yeah, that's a great question. So, I mean, even at the end of the clinical trials, there were people that got COVID-19 that got both doses of vaccine. And again, we do know based on more and more real world data, data that's come out of United Kingdom recently, where a household member of someone that has a COVID-19 vaccine has a 30% reduced risk of getting COVID-19 themselves, which is a big thing. Similarly, in Israel, where we're seeing rates, amongst transmission going down, what we're seeing in our long-term care transmission going down. So, absolutely, this does decrease the risk of one transmitting COVID-19 to another, but it doesn't take it down to zero in that sense. And so again, the big part of this vaccine campaign is not only reducing transmission in the community, but giving people an individual personal protection from getting that vaccine as well. And that's where these, as Dr. Bogoch was talking about earlier, where these public health rules after vaccination come into place so more, such that, yes, people may be transmissible to others, but in their own personal context with multiple people vaccinated are probably extremely low risk of having anything bad happen. And really balancing all that part out, where people might still be a bit transmissible, but may not be at risk themselves of significant complications.
Thank you so much for that. And thank you for everyone juggling my technical difficulties. It's always a challenge sometimes. So I think the next question we have is from Mr. Dougal at QP Briefing. And it's around, of course, initially with the third wave, but I think we've covered that. So can we speak to what the data is saying on possible transmission after an individual is vaccinated? And I know Ray had the same question as well, Ray Chan. How does that compare to those who aren't vaccinated? And can you still transmit the virus post-vaccination?
Yeah, I think I just covered that a little bit, but yeah, again, people can still transmit at the end. Again, even in the Pfizer Moderna trial, there was a small percentage of people that got COVID after getting Pfizer Moderna. And so, yeah, absolutely, it's still important that people who are fully vaccinated get tested when still having symptoms, that they when going out towards public facing settings, still adhere to all the public measures in terms of masking, distancing, and all that stuff. But yeah, there are certainly people that can get COVID-19 after the vaccine. The good news is these people are likely very, very, very mild disease, and again, not necessarily a big healthcare strain or a death strain or a death risk that we worry about.
Apologies for making you repeat yourself. And so, of course, the answer there lies in the fact that even 96% efficacy means 4% are still possibly going to get the disease and therefore possibly going to be able to spread it. And that's why we keep saying to people, even after you're vaccinated, you still have to keep maintaining those public health measures of wearing a mask, et cetera. I know there's also been a lot of discussion about vaccine passports. Dr. Dubey, I think you have an opinion on this. So would you like to share with us what you think about vaccine passports? Do they have a role? Are they necessity? And what are they anyways?
Yeah, what are they? Actually, I would like to know that as well, too. I think there's no question that vaccines are required in some countries to travel. Yellow fever is a vaccine that's required in certain countries, for example. So that's an example of a vaccine passport. And so for international travel, it could be that you're required a vaccine to enter certain countries. So you could see how a vaccine passport might work that way. I think the question becomes, people think that, can you get a vaccine passport to go to the cinema or to attend a live sporting event or a theater event, for example? And it's hard to know how that actually could work or would work. How do you verify vaccination status? Is that enough? Do you actually not need any other public health measures? So broader, yes, probably for travel can happen. There is that infrastructure available, but on the ground, what it looks like every day having a vaccine passport, not clear on how that could roll out. And with that, I have to log off now, but thank you everyone for your engagement, and I really appreciate it and had a great time, so thanks.
Thank you. Our panelists are dropping like flies today. This is not a good sign. Dr. Dubey has to leave, but before we close the session, I will turn to our remaining two panelists and ask, what is the one thing that the public or the healthcare profession or the government could do to prevent or prepare for another pandemic? Dr. Chagla, do you want to go first? I see you reaching for your mic.
Yeah, I mean, I think there's a couple of things we learned from this pandemic. One is that, in the context of everything that happened, how much we are globally connected to other places for things like equipment, PPE, testing, vaccines, all of that stuff. And so, it would be impossible to say a country as relatively small as Canada to build up the entire capacity to do all of this on its own, but to prepare, to stockpile, to have good supply chains, to really have that line in the sand to say that we do need to keep supplies for ourselves. And I think the other part of this, and we've done good jobs, but even with everything going on, is really centralized, transparent, open communication, and really engaging on all platforms. Right? It's not as simple as going on the news and being as appropriate. I think webinars like this are really, really helpful too for the press. But we have to meet people on every different media they can have possible. We know misinformation circulates on every media possible, and people unfortunately do believe that it's a balance sometimes when there's a ton of material of misinformation and very small amounts of material that are true information. And so it's up to us as healthcare providers, as public, as media, to actually engage on every single platform to make sure that people are getting information kind of from every source moving forward.
Absolutely. Kind of exhausting being on all of the platforms at the same time, as you know, but it's absolutely essential. Dr. Hanna.
I was going to echo the exact same 2 points that Dr. Chagla made. So let me repeat them then. Communication, I don't think that this can be dismissed. Communication happens on so many different ways. It happens with physicians one-on-one with their patients, but also in the media and in the social settings. And I think vaccine misinformation, COVID misinformation initially, when we didn't recognize that, was quite the issue. And I think as physicians, we've responded and adjusted, and it's great to see that media and other platforms have also adjusted to get information into people's hands. And certainly with this pandemic, as every detail seems to evolve from 1 week, from 1 month to the next, it's important to have accessible information into the general population's hands. And then preparation. I think this is just a new era in health and in medicine where public health strategies that allow us to prepare as a nation are going to be essential. Are we at the end of the COVID-19 pandemic and the beginning of this variant pandemic? Are we starting into a new pandemic in the future? Well, honestly, time will tell, but we do need to be prepared, and resources are going to make our frontline workers prepared. And I think we all know that that's essential now.
Thank you so much for that, Dr. Hanna. And I guess as host, I get to have closing remarks. So I'm going to add my thoughts to that, because I'll actually take a little bit of a different slant. We've seen with COVID a disproportionate effect on our most vulnerable. And yes, of course, that included the long-term care citizens, but it also included racialized communities and communities that really suffer from lower socioeconomic demographics. And I think that one of the things I've learned, at least from this, is how inequitable our healthcare system is, even though we aim for equity across the board. And I think there's a lot that we can do as healthcare professionals, but also from the government and society at large, to try and even out our baseline access to healthcare. And much of what we've seen with COVID is really just a reflection of longstanding problems. And I think that we have a lot of work to do there as a society. With that, I will say thank you to everyone who's still with us for attending today's briefing, for your great questions, for your time, for your energy. I hope that this session was helpful in informing your reporting. As always, I look forward to watching and reading your coverage. Again, if there's a topic that you would like to hear doctors discuss, or if you have questions on this topic, please feel free to email us with suggestions or questions at media@oma.org. A little bit different tonight, I'd like to invite you to attend our OMA Talks event tomorrow night, which is a panel discussion and question and answers about lessons learned from COVID-19. So very similar to this. Expert panelists will include Dr. Adelstein Brown, Dean of the University of Toronto's Dalla Lana School of Public Health, palliative care physician Dr. Nahid Dassani, Chair of the OMA Section on Palliative Care, Dr. Pamela Liao, Dr. Kieran Moore, Kingston's Medical Officer of Health, and our own Dr. Jim Wright, the OMA's Chief of Economics, Policy and Research. I hope that you can join us. I think there'll be a lot of excellent news there as well. And I thank you again for your time. Stay safe and stay healthy.